respected chairpersons, and dear friends. Well, I bring greetings from Nepali Society of Neurosurgeons, on behalf of which I represent here. And at the outset, let me thank the organizing committee, the Endoscopic Spine Surgery Society of India, as well, in particular, Dr. Malcolm and his family, for being a wonderful host and organizing such a wonderful meeting. This is really a tough thing, and this whole environment actually vibrates with your energy. Well, my topic is to bring forward and highlight on how the program has actually developed in my place in Nepal. And since I work in an academic center, there are a lot of things which may be represented to most of you. So I have nothing significant to disclose regarding this presentation of mine. So I take minimal invasive surgery as a philosophy, because if I say it as a procedure, we are so much evolving. With every 2-3 years, we see new technology coming up in this field. So it is just like trying to pluck a mango, a first ripe mango of the season from a beehive. So you're not damaging anything, at the same time you are getting maximum. Well, there are two related things when we talk of MES. One is maximum working freedom, and as we see the technology evolving, we are looking a lot more working space inside the cavity, which is either being created by water or by the other media, as well as it should allow us some extension of our ability to extend our workspace, and that's how the MES philosophy is actually evolving over the period. Now, since being trained in microscopy, we were trained into that much extent that we were told that we could actually eat with a suction and a forceps food. But then what we found in endoscopy is that endoscopy actually brings the illumination and the magnification to the depth, and henceforth it increased the expanse of vision in the depth, which a microscope may not be able to do that. So, and then over the period, we have seen that there has been an increasing application of endoscopic procedure. Even though it's called minimal invasive, it is going in much more invasive proportion. And if you see the publications over the years, in the last 2-3 years, we are seeing expanding amount of publications in this field of endoscopic spine surgery. Now, it has really become a necessity. This started with some exploration, something to adventure for, because we as a surgeon need to do something extra, what we are doing routinely. But later on, we realized that minimal invasive surgery is just not a fad. It is just not a cosmetic surgery. It has a lot of physical benefit to the patient, not only in terms of quick recovery, but early discharges, minimum rehabilitation time, cost reduction is there because you are not creating instability to the patient, and also additional advantages like low blood transfusion effectiveness, less pain, and motion preservation. And this has been shown sufficiently in many randomized clinical trials also, where they have compared the endoscopic and minimal invasive spine surgery compared to the conventional surgeries. However, there are definitely some challenges. The major challenges which we face as a learning period during my first decade of this practice had been the confusing names. Every year, with every new publication comes a new name in the field, and that's why the names have been very much confusing. Similarly, we were better trained in microscope. There was always a tendency to revert back to microscope whenever there was a problem in endoscopy in the initial period. And then we used to reverse to the open exposures. So this could be because of the lack of exposures and trainings. And of course, the initial cost of equipment. So this is one of the field which I realized that the business in practicality has actually entered into the endoscopy much more earlier than any other field. Henceforth, we have very much procedure-specific equipment in literally every company which sells its equipment. So we end up buying a lot of equipment for a similar looking procedure. And that's why it increases the cost of equipment. And also there's a learning curve and fear of complications. However, there has been some attempt to demystify this particular confusion with the name, with full endoscopy, biportal endoscopy, and microendoscopy. And what we are now looking at is a UVE techniques. And also the AO spine has been very much aggressive in classifying the endoscopic spine procedures. Well, we see a lot of uses. In Nepal, we are using this MIS technique not only for the disc herniations, but also to an extent of dealing with the spine infection, spine tumors. And we are getting good patient satisfaction. Patient reported outcomes are better. And also the operative times, as we started this process, has started coming down with lesser morbidity and decreased birth state. However, this transformation had been very gradual because we had a lot of investment to be done on equipments, and also the concern with the safety was there, and expertise actually builds upon with a lot of practice. So we started with microdiscectomy or microscopic use of dural repairs. And then we went on to a procedure known as hemilaminectomy, where we could actually attack the intradural pathologies by opening a very small corridor inside the bone. And then we started using tubular devices and then the endoscopic devices. So this paper of ours on MIHAM, or microscopic hemilaminectomy, was also awarded as the best paper, which we could actually approach the intradural tumors through a minimal 2.5 to 3 centimeter incision on their skin. However, this particular approach actually led us to the belief that we could go inside the interdural space even through small cavities. However, there was an inherent advantage of MIS techniques over this particular open technique, and that was the muscle dissection. So when we see the muscle coming back to its place, this is something which we never get when we are doing a subperiosteal dissection or when we are cutting through the muscles. And henceforth, we were now transiting more or less into these dilatation method of MIS or endoscopic techniques, where we are now going slowly into the intramuscular techniques rather than subperiosteal techniques. So this is how we started with our tubular methods of dissectomy and removing the small disc, extruded ones, from interlaminar approaches. And of course, we had actually used mobile technologies like a distando technique also in our scenarios. The little bit difference what I found in the distando technique was this: since it allows us a two-hand movement inside the tube, we could actually place a neurocotton inside, play with the stuff very delicately, just like in a microscope, with the added advantage of better illumination and microscopy. Well, but then there's always a challenges when you are operating inside the tube. As my previous speaker did talk about the parallelism. So the instruments, one has to come out if you're putting the other instrument in. What we are now finding is the UV technique is much more better because it allows two instruments to be inside at the same given point of time, and that actually is a help. Considering the fact that we are the neurosurgeons who are operating with binostril technique inside the skull base, much better with much control, and a lot of dissections can be done. To this fact that nowadays people are doing two ports inside the skull, one from one side, the other from the other side, to go inside the ventricle, and they open up the septum pellucidum, just like septoplasty, and then they can operate inside the intraventricular tumors. So this UB technique is something which we are looking forward to, and I'm very thankful to Dr. Malcolm, his initiative in this particular part, that we in our country are also trying to bring this UB technology to our place, which we're finding a lot more benefit. So contrary to the philosophy to mitigate the collateral tissue damage and stabilization and avoidance of fusion, we are now looking at the role of endoscopy to assist in fusion technologies under vision, which is never heard of. Even in MIS, there's a step in which you are rimming the end plate, you are putting the cage without any vision as such. But then in UB technique, everything is under vision, which is absolutely fabulous. So, but then there's always some challenges. So we require some equipments to go ahead with this technology. And then there's always a radiation overexposure, which we all risk. But then these all are related with the use of navigation technology, as in case of C1, C2, C1 fusion, we could only do away this procedure with just 4 exposures of fluoroscopy. We find there's a learning curve, but then this again is relative. The best part is that this technology was developed in Asia, and as an Asian neurosurgeon, we are proud to say that this technology is here to stay, and we are going to evolve it further. So to conclude, endoscopic spine surgery is not a specific procedure. It's just a platform where it facilitates better visualization and access to the spine while mitigating damage to the surrounding healthy tissues. And it has a role in mitigating the cost of treatment. It has a direct to consumer appeal, and with the supported technology, the navigation and automation tool, which assists surgeons, we can see expansive growth in this technology in years to come. Thank you for the patient listening. And on behalf of NESON, I'd like to invite for the next year's meeting. It's an international meeting in September 2023 in Kathmandu. So a brochure will be circulated soon, and I will send it to all of you. Thank you.